Welcome to the Dusty Muffins, where menopause meets sisterhood and strength. We're three menopause specialists coming together to laugh, share, and empower you through the wild ride of menopause and perimenopause. Whether you're curious, confused, or just looking for real talk, you're in the right place. We're here to answer your burning questions, educate, and advocate, all with a dash of humor and a lot of heart. So pull up a chair and join the conversation. Before we dive in, please remember, while we're doctors, we're not your doctors. This podcast is for educational purposes only and is not a substitute for medical advice. We encourage you to partner with your own medical clinician to address your unique health needs. This is the Dusty Muffins.
Welcome back to the Dusty Muffins, where menopause meets real talk, good laughs, and absolutely no one-size-fits-all nonsense.
Because let's be honest, if menopause were a t-shirt, it wouldn't come in a one-size-fits-all. It'd be a clearance rack mess of options that just don't fit right.
Some women breeze through it and others feel like their body went into a full-on rebellion mode. And guess what? Both are normal. Today, we're breaking down why menopause is not a one-size-fits-all journey and how to find what actually works for you.
So grab your tea or coffee, we're diving in. Today, we're talking about why it's not a one-size-fits-all approach when it comes to menopause, right, ladies?
You got it.
Yes,
Where will we start?
All right. Do you want to start with introductions over here in the snowy Erie, Pennsylvania? I'm Dr. Rebbecca Hertel. I'm on board certified osteopathic family medicine physician and a certified menopause practitioner in Pennsylvania.
I'm Aoife O'Sullivan, a board-certified family physician and Menopause Society certified practitioner, coming to you from Portland, Oregon.
Hi, everybody. I'm Dr. Hart Kress. I'm a board-certified women's health nurse practitioner and a Menopause Society menopause practitioner, and I'm coming to you from Northern Virginia.
All right. So, yeah, go ahead, eh? You got something?
No, I was just going to say today we're going to get into why, for instance, I give a lot of talks to the residencies locally here in Washington and Oregon, and they usually give me like an hour, a stingy hour. And I'm always like, am I doing more harm than good? Trying to squash things into an hour, because I think I leave those clinicians thinking, oh, I can do this. I'll just stick a patch on her, and give her some progesterone. And we know that every woman is completely different than the next, don't we? Like every case is so nuanced.
Yeah, it is.
I find that when I start all my visits in the same manner. Obviously I want to hear people's journeys and where they have been, what experiences they've had with other providers, or if they've been on menopausal hormone therapy. What I'm finding right now is that 6 months ago, women were coming because they couldn't get anybody to prescribe. But what I'm noticing now is they're coming because they feel like what they're on is not quite right, and they want to be tweaked. Like they feel like it's not individualized, that no one has looked at their whole picture. And so I always start out by teasing through their symptoms. I love looking at that green climacteric menopausal score, and have women score out their symptoms, and then really go through and figure out what symptoms are really bothering them. Because whether you're tweaking someone or new starting them, you always start with what hormone needs to be addressed by where the symptoms are, if they're low estrogen symptoms, progesterone or testosterone, because ultimately what we want to do is make women feel better and relieve those symptoms.
Yep. Yeah. And I see a lot when, and we're just talking about menopausal as a one size fits all, and we'll do another one on perimenopause. So, I find that there are patients that'll come in and they're like 0.05 patch and this, and that's where they were from like the gate or a combi patch. And they're coming because either they're bleeding, their estrogen's too high, because they were just kind of put like on this, this prescription that I think that these, practitioners were just taught, and that's how they were taught to do it. So in one respect, you're like, I'm so happy that they gave it to you. But in the next one, you were just like, okay. we're going to have to fine tune that and tweak that a little bit, because that doesn't work for everyone, right?
I agree. Yeah. So I'm the same. I really feel like over the last few months, I've been seeing so many of those particular patients who are on something, and then they go back to follow up, and their clinician has kind of maxed out on what
Yep.
they know.
Mm-hmm.
Which is understandable, right? Because we don't get any training in this. And so that clinician has probably thought, oh my God, this is all missing from my training. I'm seeing it all over social media. People are talking about it. My patients are asking me about it. I need to learn something. And so they do their best. And then they get to a point where, unless you've had a ton of experience or unless you've done a particular course, you're just not going to know what to do next, And I have had those women come in who are, in their late 50s, haven't had a period in many, many years, and were slapped on, a 75 microgram patch and are now bleeding. Or a poor perimenopausal woman who's in her early 40s and is on this 25 microgram patch, and it's not doing anything for her, So, yeah, that's funny that we all feel like we've been seeing a lot of that. It must mean that clinicians are trying.
Right.
Yeah.
Right.
Yeah.
Which is good,
Yep.
but you're just like, okay, now what do we do with this? And I think, and let's go back a little bit and talk about, why does this vary for every woman? Let's kind of take it back and to why at least we all take an individualized approach. Do we take genetics into effect? Like, do you guys ask your women like, hey, what was your mom's menopause? What about your aunts? What about, at least a question of, if they talked about it. Do you find that there's a correlation there at all, at least for some symptoms?
For me, nobody knows. I mean, this is not something that's ever been spoken about in any family, I think. There's the rare patient that you come across that says, oh, my mom went into menopause when she was 37, or, but other than that, I find most of my patients don't know what their mom or their aunt went through. Yeah.
Mm-hmm. I think that's a good point. And, I counsel women, this isn't your mother, sister's, daughter's, friends, menopause. You're not going to have your menopause experience is not going to be like someone else's, because I want to remove that expectation that they feel like, they're not doing it right or they're worse than someone else. But, I haven't found that women model their mothers at all. And, in the cases that I, talk to women, and, and that's, some of that might be my own personal bias, because my mom went through menopause at 41 and I'm sitting here at 53 still trying to figure out if I'm menopausal, because I don't think I'm quite there yet. My lab work says I'm not quite there yet. And so I used to think, like 30 years ago, I used to think, oh, you're going to do it just like your mother. And now I think, just based on my personal experience, I now just have this thought in my head that and just from talking to people, that it doesn't really run in lineage, is what I'm noticing. But I'm also fearful of, pointing that out, because I don't want them to think, I just want them to have their own experience and not be biased or tainted by what other people had.
Yeah. I feel like I get more so the point, like both of you, where my patients don't really know, but I do have some that have said, hey, my mom went through it like 45, or my mom had really horrible hot flashes and really terrible mood. And, this started for her about the time that this is starting for me. And sometimes that helps them understand. And I had that same discussion with them. Your menopause and your journey is yours, but sometimes it helps validate what they're going through, because mom did as well, or or if they had abnormal bleeding or fibroids or whatnot. Now, what about the differences in even just ethnic and racial differences with menopause experiences?
Yeah, because there's a study going on across America, the SWAN study, the study of women's health across the nation, that's been going on since the 90s, I think.
Yep, 96.
Yeah, and so those women were perimenopausal, I think, when they entered that study. And it's a nice slice through America when you look at the women who are involved in it. They are not just white American women, which so much of any research that we do have on women in America is based on. And so we do have loads of information from that. And we see that African American women in general, especially when it comes to vasomotor symptoms, theirs start earlier, they're more severe, and they go on for longer, for more years. And we know how dangerous vasomotor symptoms can be for our brain and our heart.
And the interesting thing that I was just listening to a lecture this week is that they're least likely to seek care because their mothers and their aunts and their grandmothers didn't talk about it. And so I think that is a really interesting point. And in that particular lecture, the point of it is that as providers, we should be asking, the pre-menopause counseling and opening up the door, because if we don't open up the door for women to feel comfortable talking about it, they're likely not going to, and then they're going to suffer for much, much, much longer than what's necessary.
Yes, and I think it is, and it's very important to, to also understand that when you take care of a diverse population of women, that I think it's even more important to open up that conversation so that way your women know that they can talk to you, that you don't understand that there are different racial and ethnic symptoms and experiences that are being had, and that we're not going to generalize their experience either. And we're not going to, it's as much important as our next female patient. And so, like our Asian women and bone pain and even the Latino population has more severe hot flashes and night sweats, and those can last longer as well, or somatization, where it's more muscle pain and body pain as well. So it's just really important for our listeners to understand that there are very much differences in the way menopause is experienced in women, and that's not a one size fits all. So, and that's very important for practitioners to understand that and to address it.
Yeah. Go ahead, Eva.
Oh, I was just going to say, I was thinking back on that graph from the SWAN study, and I think it was...
I have it.
You have it. African American and Hispanic women were affected the most when it came to vasomotor symptoms. Caucasian women were in the middle, and then American Chinese and American Japanese women were affected the least, just when it came to vasomotor symptoms. That doesn't mean any other menopausal symptom. But I just find that so interesting. We don't know if it's genetic, dietary, a difference in the quality or the availability of medical care. Like, it's so interesting, probably multifactorial.
Very much so.
And the thing I thought was really interesting is that, Hispanic women will peak in late perimenopause with their symptoms, and then by menopause, they're over. And then Chinese women, their symptoms, especially vasomotor, are highest post-menopause. And then there was, in that same lecture, they were talking about that because of the high soy intake among Japanese women, that only about 50% of women will actually have any vasomotor symptoms, and that there's peak just tiny little bit, but the lowest of all the ethnicities in the perimenopause, late perimenopause, and then postmenopause, they're not having problems. And the thing that's frightening about that is that a lot of women don't seek care if they're not having vasomotor symptoms. But Asian women are so much, they're smaller
Right.
structure, smaller bone frame, to see osteoporosis and osteopenia, and they're not seeking care because they're
Huge.
not miserable. So I think that is, something, that's why it's just so important for clinicians to ask, and then to realize that everyone experiences their symptoms at a different, at different time intervals.
Yep. And I find it very important when I'm educating also, different women that I take care of, that I let them know that exactly what we just said. And, whether it is a Latina woman, a Black woman, a woman of color, or an Asian woman, I give them all of that information. And almost always they're like, I never knew. I just thought it was a little bit of hot flashes. And I'm like, no, those are really important for you to take care of. Those are really, they affect your brain and your heart. And so, they really appreciate too that you're just discussing menopause, and that it's not a one size fits all, but then you're also coming back to like, I see you as an individual and that you have different risk factors because of that. And we need to talk about them.
Right. And depending on, how they present, it gives you a gauge of, where you would start in terms of hormone therapy, because, those super flashers that are having tons of hot flashes that are like the media where they're soaking wet in bright red are going to need a higher dose of menopausal hormone therapy than someone who says, my hot flashes really aren't that bothersome. You can start them much lower. So, looking at, their symptoms, and then being aware of, hey, they may start out not bad, and then when I give them a little hormone therapy, their hot flashes may get worse as they make that transition through. So, and I think one of the things women need to realize is, it is absolutely normal to be on multiple different doses throughout there while we're figuring it out, different routes. Try them all. Your insurance will pay for almost all of them. They're a little tricky on that femring, but try it out and find out what works for you. And I think people are afraid to say, I don't like it. Say, I don't like it, because whatever you pick, you can, it's the next 40 years. So let's experiment and figure out which one works for you. And if you're still having symptoms, it's okay to go up on the dose.
Yep. And our receptors, right? Not everybody's receptors work the same way. So you could be great at a 0.025 depending on your receptors and how saturated they get, and some don't, or the route and how your skin absorbs or your gut absorbs. And so that is another reason, this one size fits all, because everybody's receptors are different, and where your body decides it wants to take the estrogen, progesterone, testosterone first, right? You might want it in your vagina, but your brain may take it first, or vice versa. So
true. Well, you mentioned the soy in Asian women's diet, Christine. So that kind of brings us on to lifestyle factors, doesn't it? Because that soy has phytoestrogens in it, so plant estrogens. And if you eat a lot of plant estrogens, they can definitely help with, like, we do see dietary differences in women's and what symptoms they have and how. And we see a difference depending, like if you are having terrible hot flashes and you are able to lose weight. Now, it's very difficult to lose weight in perimenopause. You're having hot flashes, your sleep is obviously disturbed. But if you are able to lose weight, we do see that your hot flashes improve, so, and then exercise can help as well. So lifestyle, will we talk a little bit about lifestyle factors and how those can,
we were talking about, wine a few minutes ago, and, it's a sad, sad sight, but at least for me, I live in the middle of wine country. I think I've said this before. I really don't have a wine problem, but I used to enjoy wine. And, I'm finding now that I metabolize it much differently. A glass of wine, I might as well have drank the bottle of wine because it goes to my head, very, very rapidly. I don't sleep. I have hot flashes all night. And, that definitely, is a factor. And, of course, the Surgeon General has, put forth that, smoking and alcohol are just as dangerous and, for cancer risks. And so, alcohol, and then highly refined processed foods and sugar. That's also going to be a problem for your menopausal symptoms as well as your metabolic health.
Yeah,
Right.
anything that's inflammatory, right? We tend to really overreact to things that we used to be able to tolerate and were inflammatory, like sugar and alcohol. And I really think that going through the menopause transition and that lack of estrogen on has such an effect on our liver. Like we see what happens to our cholesterol production; it really ramps up, and the liver is integral to so much metabolism when it comes to alcohol as well. You have to wonder, is that the link? That our livers are no longer able to metabolize that alcohol properly. And then I don't know if you guys see this a lot as well, but I have it and I see it a lot in patients, is that mast cell destabilization that occurs. And people will say they get that flushing a lot. Certain foods and alcohols. And, I think rosacea is probably tied into that a little bit as well. All these things that we don't 100% understand. But obviously our hormones are so involved and integral in those processes. And we start to get it then during the menopause transition. And it just makes everything so much more miserable.
Yep. Yes. And I think, there comes that important discussion of, good lifestyle habits and not smoking and, minimal alcohol or no alcohol, good sleep, all of those things that we really should be doing, in our 20s and 30s, and which would, it'll be interesting as maybe that shift changes to see how the perimenopause and menopause transition will shift. Will it shift? Will they have a better perimenopause and menopause if those lifestyle changes are it's something that they are taking on earlier in life? It'll be interesting. We need the research.
We do, because we see it ourselves and we see it in our patients, right? That once we are able to start working out, if we're able to make changes and get some sleep, things do turn around, don't they? Like our lifestyle factors are so important, not just the hormones, but I feel like a lot of us go around so exhausted and kind of in this inflammatory state that even our adrenal glands, which produce testosterone on a daily basis, probably aren't functioning that well. And when you are getting your sleep and you're feeling better and you're in a less inflamed state, you're pumping out more testosterone, which can get converted to estradiol. And so just overall feel better and healthier, even hormonally.
Right. And that testosterone goes up, and then, maybe some other things are wanting to happen a little bit more often too, because you're getting your sleep and you're
all
getting
connected. Exactly.
Yeah.
It's better, you have energy. Yeah.
Yes. Yeah. You want to be intimate with your partner, or yourself or whoever. And so that all plays a part in that, and I think that, so, lifestyle factors, but underlying health conditions too, right? So making sure that you're managing your thyroid disorders and your diabetes or your impaired fasting glucose or, other autoimmune diseases like rheumatoid arthritis and things like that, because those can all flare and get wonky too as you're going through that transition. And so it's important that I think that either your endocrinologist or your rheumatologist or your primary care provider is also understanding that maybe there'll be some changes as you're going through this menopause transition, so that they also need to understand that, and make sure that, you may see some changes where you'll need to tweak some medications or that maybe, your fasting glucose is going to be getting a little bit worse when it was under control and now it's not in control. So.
Yeah, and I think the other thing too is women with a history of PCOS or infertility, if they have spent a lot of time in their earlier years skipping cycles, I think, that's one thing for them to realize, is that if you went a lot of years without ovulating, then you didn't, you still have a lot of follicles. And so you may go through menopause much later. You may be that 5% that goes through menopause after age 55. And then for those women, our infertility and our PCOS patients, those are classically associated with low progesterone. And so a little bit of progesterone often will help women early in the perimenopausal period. And that's all they need is to replace that progesterone. But I think, people, women, you never know when you're going to go through menopause, but you breastfed for a long time, you had lots of pregnancies, you may wait and go a little bit later than other people who've been marching right along, having monthly menstrual cycles and ovulations.
Yeah. What about the problem with a one-size-fits-all approach? Let's kind of move on to that. Like, some outdated medical guidelines, maybe what some doctors are still saying to patients. Let's talk. I know we could have a whole thing on that. Some misinformation and myths, maybe some of our favorite ones there. And, how menopause symptoms are still being overlooked. So maybe let's start with some things that some docs are still saying to our patients. What are a couple of your favorite things about the outdated medical guidelines for practitioners?
Oh my gosh, there's a couple that drive me bonkers. One is you're still having periods, so you cannot take hormones, which makes no sense because we all know the most symptomatic period is when you're perimenopausal. Once you're postmenopausal, your symptoms will often taper off over a few years. So when you really need that help to carry on a normal life and keep your job and your relationship and your marbles is when you're perimenopausal often. And then so that's a big one. So you have to be menopausal to have hormones.
Right. Wait it out. Sorry. This is just part of life.
And, in that same breath, I have been hearing an uptick of providers telling patients, well, you're still having a period, so you can't have any hormone deficiency. Everything's normal. Right.
It all looks normal to me.
It all looks
normal. And I have to tell you, I had both to that point, I had a patient that had such horrible GSM and vaginal dryness that going to the bathroom was painful to use tissue.
Oh my gosh.
And whether it was a G1, and it doesn't really matter who it was, told her, I'm sorry, you're still having periods. I can't help you. Not even vaginal estrogen. And I'm just like, when you feel like sandpaper and you can't even, clean yourself up after you go to the bathroom because it's so dry and tender and friable. I'm like, how it baffles my mind how anyone can say, it's just part of life.
To try and find out where this comes from, right? It's like if you were to ask that clinician one more question, just what are you basing that on? Which book?
Where did you learn that?
They won't be able to tell you because it's literally this myth that floats around. But the only thing I can trace it back to is the straw guidelines, which I think we mentioned in a previous episode, which were developed for research purposes to categorize women into whether they were menopausal or not menopausal.
Or not.
And it kind of categorized the different stages of perimenopause, the menopause transition overall. And, it quite clearly says the first stage is where your periods get a little irregular, and then the second stage is where they get more irregular. And I honestly think that's where all this comes from, because people think this is some type of scripture.
Right.
That is not how women work. That's not how any of my patients work. I don't know who they were basing it on, honestly.
Right.
Well, I mean, I have so many patients who are riddled with every single symptom.
Yep.
I say to them, I don't know how many of these are due to perimenopause, but we can start you on hormones and see. They come back, they're
Right.
so much better. So I have my answer. And
Mhm.
yet they will tell me their periods haven't changed at all. So this is really a myth that we need to get past, and is a barrier to care for patients. It's dangerous.
It's a huge barrier to care.
Yeah.
This misconception that menopause is natural and to just deal with it. And how many times have we said, well, losing our eyesight is too, and
Yeah.
we wear glasses and we get readers, and there's so
Erectile
many things that
dysfunction is
happen.
still being normal.
Erectile dysfunction is normal. You're right.
Hemorrhoids
You
are
are right.
normal.
Hemorrhoids are normal.
Your uterus falling down through your vagina is normal, but we fix these things. We help our
Yeah.
patients. We don't let them suffer.
It's a good point.
It's
Good point.
No. Yes, I'm not like, we're not going to be dragging our uteruses on the floor,
So I did
mean,
have
we're going to pick that up and
I did have a lady. I did see a 94-year-old came into my office. This is when I was in private practice, and she kept telling me that something fell out, and I was like, I'm like, really? Falling out? And she sat down on the exam table, and kid you not, the entire uterus, I saw her inside out cervix. I was like, oh, bless your little heart. It really is falling out.
Yeah.
And so we pessoried that thing back in and got her some help, but poor little thing.
I saw that with a rectal prolapse. A little old woman. Yep.
Yeah.
Same, because all that stuff is your pelvic
uterus.
floor.
Why did you think that, Christine? That was completely natural.
That's right.
That was an aging process where her tissues got weak and the uterus collapsed.
Yeah.
No.
It's just part. It's just part of aging, right? Like that pelvic floor just gets
so
loosey.
That shouldn't need to be fixed. The lady was carrying her uterus in her underwear. I'm like, oh my god!
It's called a uterus sling. Let's rename it.
That's right.
It was like a 10-centimeter uterus. That thing is. That's like,
that was a fanny.
That was big. 94. She had a big one. But, I think one of the things that, for patients to know that their symptoms are probably being overlooked is when you start doing the ologist march, meaning that you're going to the rheumatologist for your joint pain, you're going to the orthopedist for your, for your frozen shoulder, the ENT for the ringing of the ears. And so yesterday I was with a group of women, and that they were reporting that they were being sent to all of these specialists, and they were they were giving pain medications and antidepressants, and basically by their primary, who just haven't been trained, we're just treating each symptom one at a time and then sending it all out for referrals because there just isn't enough education to understand. And you can't blame providers, because I was one of those providers. Like, I couldn't figure out why the anxiety and the plantar fasciitis and, the joint pain and the heart palpitations were, how they could possibly be, related if you're not taught perimenopause and if you're not taught menopause. But for patients, that's your ding, 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 that it's, stop, find yourself someone who can look at your hormones and, then decide if you need to move forward with the rest of your 1,000 referrals.
Yep. Absolutely. Okay. So let's talk about some personalized approaches and what actually works. So HRT and non-hormonal options, we've talked about that, I think. Oh, there's dinosaurs on the back. Hold on.
I know. I was like, what's happening?
Girls, all right, you girls take over. Let me go turn off my dinos.
Okay, so personalized approaches, what actually works? So, I think we've kind of talked through some of these. Our options for treatment are either hormonal or non-hormonal. Diet, as in, there are certain things that we need to change in our diet as we go through this menopause transition. We just can't keep eating like we did in our 20s and 30s, because our body's responding to these foods differently, like these ultra processed foods, the high added sugar foods, alcohol.
Yep.
These things are putting us into this really inflamed state, and it's causing havoc on our sleep and our joints. Smoking, yeah, absolutely.
And And I think it's important on the treatment that you seek a provider who offers you all the options, because you are in charge of this journey, and you need choices, and you deserve choices. So if you have someone who says you can only be on X, then that poses a question. Are all the other things contraindicated, or is this the only thing that you prescribe? And so, I think women really need to have a plan, and, but providers need to present all of the options and let the patient decide. It's, we don't need to be the one that decides, because in the end, the only thing that matters is, one, is there any absolute contraindications? And two, is it something that's going to work with their lifestyle that they can actually manage and that they'll do, and they feel good about doing those things?
Mm-hmm. No, absolutely. And I think, the last few things is that there are also other things that women can do to help ease some of their symptoms, and especially if they're not ready to do hormones or they can't. I want to be clear that, when you're losing estrogen, you got to replace it, but you can choose not to replace it, right? So, and not just estrogen, but estrogen, progesterone, testosterone. However, there are a lot of options that women do choose. And I was talking with a colleague who actually does acupuncture, and had said that, she was treating someone who couldn't do hormones, and it really did get rid of their hot flashes, and it was really helpful. And so, when we think about certain supplements or mindfulness and CBT and, therapy and things like that, that there are other options out there while you're trying to figure this out, or if you're just not sure, or, you can't, or if you just choose not to, because we do have women that just choose not to, and that's okay too, as long as, they have all the education that they need. That there are also other, I guess, alternatives as well to help mitigate some of these symptoms.
Absolutely. And, the great thing about being telemedicine, right? When you say what supplements you're on, and and patients say, hold on a minute. And it always makes me nervous when the supplements come over in Rubbermaid containers.
Yeah.
Yeah.
Or we all travel to the cabinet, and they just keep coming out.
Yeah.
And I'm like, and a lot of them, I'm like, I've never even heard of, because I think a lot of people hear things on social media, and they,
Yep.
Try this, try that. And so, women are taking a lot of supplements, and they may or may not be useful for them. And they're spending hundreds and hundreds of dollars. And I think, my best advice is get your get your ferritin, your B12, your vitamin D, your folate, get them checked. Do you have a deficiency? Because if you don't supplement it. Use food, because you don't know what all the interactions are of all of the medications. And I mean, there's no point in taking it if it actually isn't solving a problem that you have. So
It could be adding
right.
problems for all you know.
That's right. It could be.
Yeah.
That's right. And replacing your hormones is they're natural medications. When we talk about being natural, right? We have natural options, and so we want to fix those things that aren't, that you are having, that are declining, and if that's what you choose to do. But I always just tell my women, I'm going to give you all these options. I don't want you to be afraid that it's not natural.
Yeah.
Like you're
exactly.
right. So
yeah, exactly.
all right. Any other key takeaways?
Yeah, I have some takeaways ready for us. So I would say, number one, educate yourself. We always, we've mentioned a few times some good books. Estrogen Matters is always a great one. It really goes in depth into all the hormones and the safety of them. So it takes away that fear. And if you read that book, you're probably going to know more than 90% of clinicians in this country about your hormones. Number two, talk to your own clinician and see where they lie with their knowledge of hormones, and whether or not they could get you started on them, because even to get started will answer a lot of your questions. And then, maybe they're going to learn with you maybe they're open to that. Some are. But if you get to the point where you feel like you've plateaued and you are just not on the right dose for you, but so far things have really improved and you just need to go a little bit further, then if your clinician's not going to work with you, I think the only thing to do really is to go looking for more help then, and I suppose the list that we use, we always direct people to the Menopause Society, where you can find clinicians who are certified. Dr. Mary Claire Haver has a list of clinicians. Any other lists?
This is probably my two main ones, I would say.
Yeah, that's
and again, call them. If you can make a call for when you do find one and ask how they work and how they prescribe and if they prescribe and what their thought process is, that could save you a little bit of time and money as well, because not everyone practices the same, even though they're certified. So that's a big thing. Hopefully that will change over time, but yeah, I agree.
And we share some wonderful information on our social, on our Instagram accounts and social media accounts. So if you're enjoying these podcasts, please subscribe and leave a review and follow us on social media. And our next episode is coming up soon, and it's going to be all about the most common questions women ask at the M Factor screenings. So we'll see you then.
All right. Bye, everyone.
Bye, everybody.